Hi, everyone. My name is Allison Schachter. I'm a senior associate at Ideas 42, and today I'm excited to talk about the design and results of our project focusing on the provider provision of respectful maternity care in Zambia. The project was implemented under Breakthrough Research, a 5-year USAID-funded project focusing on social and behavior change research in health and development programs around the world and led by Population Council. And a bit about us at Ideas 42. We use insights from behavioral science, and that's a collection of academic fields such as economics, psychology, and neuroscience that provides insights about how and why people behave the way they do. We use these insights to design solutions to some of the world's most persistent social problems. In our efforts to focus on improving provision of respectful maternity care, we completed a 4-phase process based on a behavioral design approach. And in collaboration with our local implementing partner, Safe Motherhood 360 Plus project and the Chapada District Health Office. We first defined our provider behavior focus, and then conducted formative research to better understand the barriers and channels to that particular behavior. We led a co-creation process to develop solutions, and then piloted those solutions and evaluated their effectiveness. And so that first step was to define our behavioral problem of focus. And that was that providers do not consistently follow best practices during delivery, especially those related to respectful maternity care. And so we conducted formative research to better understand why and what those behavioral barriers were. The first theme that we found was that harsh treatment is normalized in the clinical setting. And when providers engaged in disrespectful care, there were no consequences. Midwives often experienced violence as children, leading them to default into harsh treatment as a disciplinary tactic. And on-site training reinforced harsh treatment as a means to achieve client compliance. There's no clear way for clients or peers to create consequences for providers who engaged in disrespectful care. We also found that providers focus on death avoidance over everything else and other things that you might consider for quality of care. This was reinforced in trainings, supervision, and feedback, which focus on clients and infants for survival almost exclusively, and also was reflected in the visual cues in the physical space. Midwives received no salient information on feedback and on the impact of disrespectful care on health outcomes, which are their primary concern. And last, the pain of labor and the implications of being in pain is part of the challenge. The pain of labor will have a negative impact on a woman's experience in a very direct way. But also, as women were not supported during delivery or received pain management, they were less likely to feel trust and rapport, and in some cases follow instructions. Providers would describe this, quote, lack of cooperation as a justification for being harsh. Midwives believe the pain of childbirth is inevitable and have limited strategies to alleviate it. And so based on these formative findings and our better understanding of the behavioral drivers of care, we then designed a 5-component solution package to address these barriers. And the first of which was a pain management toolkit using the mnemonic of BETTER, which stands for different pain management techniques that providers can use. The toolkit consisted of posters, which were visible to both providers and clients, a manual on the different techniques and how to use them, a cartograph guide, which prompts providers to specific pain management techniques at different stages of labor, and massage balls, which could be used to provide pain relief. And the way in which the toolkit worked was that it first frames pain management as part of the routine clinical care. It elevated pain management as a part of this clinical care and incorporated it into the provider's current priorities and how they think about their role. It expanded the choice set for providers to include additional evidence-based techniques. The toolkit cues providers to offer pain management so that it's top of mind for providers. It also addresses power dynamics by prompting the provider to be in service of a woman and by inviting the woman to increase her expectations and ask for pain management support as well. And lastly, it addresses common trigger to disrespectful care we identified in the formative research. The toolkit further humanizes the relationship and builds rapport between patient and provider by prompting a repeated and caring behavior. And next, we introduced a provider-client promise, which serves as a commitment device and was conducted upon admission to the labor ward with each individual client. It outlined the expectation and promises for both the provider and client. By setting expectations for both provider and client, it addresses power by elevating patient expectations and including items she should expect that she previously did not, such as pain management and support. It also set boundaries for what is considered acceptable for the provider, develop rapport and trust amongst providers and clients, and also invokes a feeling of dissonance if a provider considers behaving in a way that contradicts the promise. Behavioral science tells us that saying something out loud, even if there are no consequences, has a tendency to instill a sense of commitment, and we will avoid behaving in a way that contradicts that agreement. We also implemented a feedback box. Clients were provided with a token upon discharge, which they could then insert into one of 3 slots to indicate their satisfaction with the service they received. The box was placed somewhere that was both accessible to clients, but out of sight of providers so that women could privately provide feedback. And the box worked in that it elevated the importance of client satisfaction. Feedback focuses on clinical outcomes, and usually client satisfaction is less salient measure of performance. It also empowers clients to share feedback by proactively prompting patient feedback. Patients receive the impression that their experience is valued and they have a means to address their concerns. We also held a reflection workshop. It was delivered to providers at the onset of the intervention and included sessions which set out to encourage providers to reflect on current care, both from the perspective of women and providers, and also build empathy and instill a commitment to a change. It allowed providers to generate a dialogue on client cooperation and best practices, and it ended by providers reaffirming their commitment to providing respectful care. The workshop was also the channel for introducing providers to the other interventions. And lastly, we introduced Fresh Start funds. Each facility was provided with a small fund to make changes that would positively affect the non-clinical client experience. And that was in part to promote a sense of agency and motivate positive change amongst providers. And it also signaled a fresh start both for clients and providers about the care that they would receive and provide at the facility. And so once we designed these 5 solutions, we conducted a quasi-experimental evaluation in late 2019. We identified 5 facilities in which we implemented these solutions and 5 which would serve as our comparison sites. We collected baseline and endline data, both with clients and providers, conducted observations in the health facilities, as well as interviews with health facility managers. And we identified 3 key takeaways. The first was that clients at intervention facilities were less likely to report disrespect at endline compared to clients who delivered at the comparison health facility by 15 percentage points. We also saw improvements in pain management support. Clients at intervention facilities were more likely to request pain management during labor, and providers at intervention facilities were more likely to rate pain management as one of the most important tasks during labor and delivery. Descriptively, we saw a shift in the types of pain management techniques used by intervention providers at endline, and included things such as massage, breathing exercises, and change positions were commonly cited, all techniques that were included in the Better Manual. And third, providers at intervention facilities were more likely to be empathetic towards clients. And speaking with health facility providers and in charges, we found that the providers found them designs easy to implement without significant investment of resources. Our experience implementing the designs in Chapada demonstrate the potential for behaviorally informed solutions. I encourage you to visit the Breakthrough Research website for our briefs, outline the findings from the pilot, as well as more information on our implementation experience in greater detail into our behavioral insights. Thank you so much for your time.
Hello everyone, my name is Imani Akiza Marie Louise. I work for Partners in Health in Inshuti mu Buzima, an international organization working with different countries, including my country, Rwanda. I'm a nurse and I have a degree of bachelor's in public health. I have been working with public hospitals in their neonatal intensive care units past 5 years before being a mentor with all babies count intervention, and currently I'm a program manager at Partners in Health in Inshuti mu Buzima in Rwanda. Today I'm very happy and delighted to be with you. I'm very proud to present our paper about quality improvement strategies to improve the patient management of small and sick newborns across all babies count supported hospitals in rural Rwanda. All babies count is an integrated model to eliminate preventable newborn deaths and an 18-month change acceleration process intervention that provides neonatal equipment and supplies, provide neonatal training and mentorship, and the district-wide learning collaborative sessions to promote peer-to-peer learning among health professionals and promote their continuous quality improvement. Why all babies count? This is an immense opportunity to prevent neonatal death by improving the quality of facility-based care, whether preventive, curative, and transformative. By curative, we mean caring for newborns experiencing complications and caring for small and sick newborns at hospital level. Whether transformative, by promoting a culture of data use for continuous quality improvement. This study has been implemented at 7 rural district hospitals, but before was piloted into 2 hospital catchment area in eastern Rwanda, and this study looks only at the scale-up of all babies count additional 7 district hospitals across the country, as you can see mapped on this map in red cross. This study was a pre-post quasi-experimental study conducted in 7 rural district hospital neonatal care units that received ABC support in a period of 2 years from 2017 to 2019, with the data of baseline collected from April to June and from July to September, depending on the startup of the project at each site. Data collected included facility audit of equipment, supplies, and the staff, mentorship reports, learning collaborative surveys to assess providers' quality improvement skills and their confidence in quality improvement, and some additional data like neonatal mortality and number of admissions have been extracted from the National Health Management Information System. As the results in about quality improvement skills, there have been an increase in all NICU providers or staffs across all skills from aim statement, flows developing and testing change ideas, using PDSA cycles, and to using quality improvement statistics to track their progress in their quality improvement projects. As you can see on the above this chart, the arrow in green represents the data on quality improvement skills of staff in the learning collaborative sessions, and the data in orange represents quality improvement skills of staff in the fourth learning collaborative sessions. About the result on change ideas, the NICU staff developed change idea from the gap that they was having in providing quality of care in their facilities, but almost all hospitals developed change ideas aiming to improve adherence to neonatal care protocols. About 85.7% focused on improving communication with families of patients, 71.4% focused on regular vital signs monitoring. Others worked on their own teamwork approach and promoting family engagement in care. But also there are some hospitals worked on monitoring and adjusting neonatal feeds. What about the result on outcome indicators? Admissions increased over the implementation of this project from 121 to 137, but also overall case fatality rate decreased from 12.4 to 7.8, and case fatality rate among premature and low birth weight decreased from 18.4 to 11.7. As you can see, data highlighted in bold. We are very, very proud of this intervention and their huge improvement during implementation phase. As lesson learned, the All Babies Count package of intervention was associated with significant neonatal mortality reduction and service utilization in the intervention hospitals. As you know, for reducing neonatal mortality or neonatal death, it requires high resources, either human resources or other financial resources. But this intervention worked only with staff and working with quality improvement strategies to improve gaps in their performance. And the strategies, quality improvement strategies designed by health facility quality improvement teams formed at the beginning of implementation of All Babies Count shows practical, feasible strategies for replication by facilities facing similar quality gaps. I thank you all for your kind attention. Thank you for All Babies Count and Partners in Health, and thank you for all staff participating in this intervention. Thank you for GLOW conference organizers to give us this opportunity. Thank you for all.
Hello everybody, my name is Alice Janvrin and I'm here with my colleague Gillian McKay, and together with Dr. Benjamin Black we are here today to present an assessment we did on the impact of Ebola on SRH. So to situate you in the context, we did this work during the 10th outbreak of Ebola in the Congo, which went from August 2018 to June 2020. And Eastern DRC is also a conflict setting and has been for several decades. The most important thing for you to know as we start this presentation is that the complications of pregnancy and the symptoms of Ebola can be very difficult to distinguish from each other. And we're looking at symptoms such as bleeding, such as fever, such as abdominal pain, and fetal death. We did this assessment, which considered all areas of SRH within a humanitarian setting, and we looked at both qualitative and quantitative data collection, and this was done in October 2019. So for the findings, first of all, around unexplained bleeding. So both unexplained bleeding and spontaneous abortions are part of the case definition of Ebola. Which means that a woman who comes in at a health facility with these two symptoms, or one of these two symptoms, will be identified as an Ebola suspect case. This means that it makes it really difficult for healthcare workers to determine what is an explained bleeding and an unexplained bleeding, because bleeding has acquired such a special status in that context. And the varying application of this case definition has caused a lot of tension between the needs of women and the needs of the Ebola response. So most of you will know the 3 delays model to explain or to examine maternal death. And we suggest in this report that in the context of Ebola, we're looking at 5 delays. So the first 3 delays are made worse by the context, the epidemic context. So women, as they discover they have a complication while they're still at home, might delay their leaving home because they're afraid of being identified at the triage as an Ebola case and are afraid of isolation. So they might delay leaving the home. Then, because of the economic impact of Ebola, it might take them longer to get from their home to the health facility, either because the cost of public transport has increased, or because they might even try and go further afield to avoid triage. The third delay, once they arrive at the health facility, is at this triage, where because of their symptoms, particularly, as I said earlier, the unexplained bleeding or spontaneous abortions, they might be identified as an Ebola suspect case and therefore isolated. The fourth delay, which is new in this Ebola context, would be the time it would take the woman to get from the health facility to the Ebola treatment center. And this might be the time it takes for the ambulance to come and pick her up. And it can also be the reluctance of her and her family to transfer. And this can delay several hours, as we saw. And then finally, the fifth delay is once arrived at the Ebola treatment center, there might be limited or in some cases no obstetric care for this woman. So she might not have the adequate obstetric care that she needs. So an example of this was given to us by a doctor at the Butembo Hospital, where she explained this story. We had a woman with a full term who came during the night at 9 p.m, bleeding and with contractions. We diagnosed placental abruptions as soon as she arrived, as she had the signs. No active fetal movements, uterine contractions, brown blood, but the triage team blocked her in isolation. They did a local blood draw and she waited for results all night. They said the results would be ready at 11 a.m. the next day. But at 2 p.m. the next day, there were still no results. Her blood pressure crashed, and we, the facility staff, believed that she needed surgery. In full PPE, we did a hysterectomy. The fetus was already dead, but she was saved. Her results came back in the evening, and she was negative. The hospital team argued with the IPC team. They had given orders not to touch her. The mother would not have undergone a hysterectomy if they hadn't been the triage, and we would have evacuated the uterus and left it there. So this really shows the impact of the Ebola policies on some of these pregnant women. So now passing on to my colleague Gillian next to me.
Thanks, Alice. So as part of our assessment, we also looked at family planning. So what we found was that many women and their partners very much expressed a desire to delay pregnancy during the epidemic. And this was for a variety of reasons. It could be because of the economic impacts of the outbreak, or it could be because some of the women had heard about cases of their friends or family members who did not receive appropriate maternal care during the outbreak because of the policies of the Ebola outbreak. There were also quite varying views among women, so family planning users, as well as healthcare workers, on whether side effects of family planning, which, as many of us know, can often cause breakthrough bleeding, are considered explained or unexplained, and therefore might necessitate an Ebola test before appropriate treatment can be given. It appeared as though people, healthcare workers who were more familiar with family planning delivery and supply were less likely to consider this an unexplained bleeding and therefore potentially have to send these women away for testing. And this is a great quote from one of our male participants in the research, that Ebola time is a good time to plan your family. As relating to abortion care, the general discussions that were had were around the challenges of spontaneous abortion rather than access to safe abortion services, and women's real fears about being isolated at triage if they arrived with kind of having had an abortion potentially at home and requiring additional treatment for post-abortion care, but being unable to access that because they had that unexplained bleeding. Since this kind of again shows that sort of unexplained bleeding versus explained bleeding are very create a huge amount of tension in clinical decision making in an Ebola context. Another quote here: since the start of the epidemic, all bleeding is a suspect Ebola case. Even when it's an abortion, if you induced your own abortion, it's a suspect. The recommendations from this research were not short. There's a fair few of them, but they can all be read in depth in the report that you can find there if you just Google "not all that bleeds is Ebola." But our key ones were that sexual and reproductive health considerations must be embedded in the Ebola response from the very outset. This is a must-have, not a nice-to-have. And the main reason for that is for number two, work to reduce delays at every stage of the patient journey, specifically harking back to what Alice said about the 5 delays model. It's very important as well to support individuals and communities to mitigate the risks posed during and after an Ebola epidemic as relating to their sexual and reproductive health, and to formulate guidelines with sexual and reproductive health and Ebola expert involvement. What we've found in our experience is that these guidelines tend to be written either by Ebola experts or by sexual and reproductive health experts, and therefore there's a lot of nuance that's missed in the translation. We felt it was important in this context in which we all find ourselves to draw forth any potential lessons for COVID-19. Now, the most important lesson, maybe first off, is that COVID-19 is not Ebola. The transmission is very different, the symptoms are very different, the impacts on maternal health can be very different in terms of kind of confusion between COVID and reproductive health complications. However, we are seeing some decisions and policies that would probably usually be applied in an Ebola outbreak, but probably wouldn't be required in a COVID-19 pandemic. And an example of this is in the Bangladesh Cox's Bazar Rohingya camps, where there's very large COVID-19 specific facilities being built specifically for COVID. A woman in labor with any signs potentially of COVID can be sent to these facilities, delaying her access to sometimes very needed obstetric care if she's in labor, where these facilities don't have that kind of specialized services, meaning that she's losing access to very important service. That being said, a number of the lessons from our report and from Ebola in general do still apply, that sexual and reproductive health care is still very much needed in the COVID-19 outbreak, even more so in cases where, for example, girls being out of school, losing that protective influence, having a possible increase in unintended pregnancy. The loss of trust in healthcare systems due to COVID-19 can increase delays in care seeking due to fear of contamination or decreased quality of care. Screening procedures can cause unacceptable delays in provision of essential time-sensitive care, and this is where a rapid test, when it's available, will make a really big difference. And making sure that those guidelines for sexual and reproductive health in COVID are made jointly, not in silos. So thank you very much. We're going to end it there with special thanks to everyone here, and thanks from us. We look forward to your questions.